Oh, there's so many yummy vegetarian options out there. You could try like lentil soup, veggie burgers, tofu stir fry. The possibilities are endless. All right, let's dive right into our first section, GI ischemia and inflammation. Okay, so our first case. We've got an 83-year-old woman. She has a history of vascular disease, and she comes in with this really severe, crampy abdominal pain that hits her right after she eats. So what you really need to lock in here is the classic triad. You've got that postprandial pain. We call it intestinal angina. Then comes the food aversion, and because of that, significant weight loss. The mechanism? Well, it's basically stable angina, but for your gut. Those atherosclerotic arteries just can't open up enough to handle the extra blood flow needed for digestion, and that causes ischemia. So how do we nail down the diagnosis? The go-to test, our top investigation, is a CT angiography. It lets us see that vessel narrowing perfectly. A key thing to remember is that this is chronic, so the onset is gradual. It's not like the sudden, catastrophic pain of acute mesenteric ischemia. For management, you're thinking risk reduction, especially getting them to stop smoking, but the definitive treatment is revascularization to get that blood flowing again. All right, let's switch gears. Case number 2. This time, we have a 64-year-old man who's been dealing with 6 weeks of bloody diarrhea, abdominal cramps, and he's lost a good amount of weight. When you look at his presentation, the big red flags are that bloody diarrhea and the left lower quadrant pain. Now, the real clincher is the endoscopy. What we see is this angry, red, friable mucosa that starts in the rectum and just continues on up without any breaks. That continuous involvement is absolutely classic for ulcerative colitis. Okay, this table is super high yield. You have to know the difference between Crohn's and UC. Remember, with ulcerative colitis, it's always in the rectum and colon, and it's a continuous inflammation that's pretty superficial, just the mucosa and submucosa. Crohn's, on the other hand, can be anywhere from mouth to anus. It has those classic skip regions, and the inflammation goes all the way through the bowel wall. We call that transmural. That's why you see complications like fistulas and abscesses in Crohn's, which you don't typically see in UC. Okay, moving on to our next section, which is all about some really critical toxicology cases. So, for our third case, picture this. A patient with a history of depression has ingested a drain cleaner, specifically one with sodium hydroxide. They come in with this awful retrosternal pain, and they're drooling because it hurts so much to swallow. This is a really important distinction. With acid ingestion, you get what's called coagulation necrosis. It basically creates this protective scab, or eschar, which limits how deep the burn goes. But with alkali ingestions, like our drain cleaner case, it's a whole different beast. You get liquefactive necrosis. The alkali literally dissolves cell membranes, turning tissue into this soupy mess, which allows it to penetrate way, way deeper. That's why alkali burns are almost always more severe. Okay, management. First things first, always your ABCs, airway, breathing, circulation. Then you've got a 24-hour window to get an upper GI endoscopy done to see how bad the damage really is. Now, here's what you absolutely do not do, and this is a huge exam point. No activated charcoal. Don't try to make them vomit, and please do not try to neutralize the chemical. All of those things will just make a bad situation way, way worse. All right, on to our next tox case. A 45-year-old woman is found unresponsive, an empty pill bottle next to her. She's had a seizure, her blood pressure's in the tank, and her heart is racing. So this is a classic tricyclic antidepressant, or TCA overdose. You're looking for 3 things. First, you get CNS toxicity, think seizures and coma. Second, you get anticholinergic effects, so they're hot, flushed, with huge pupils. But the real killer, the thing you have to watch out for, is the cardiovascular toxicity. The TCA blocks fast sodium channels in the heart, and that's what causes that dangerously wide QRS complex on the EKG. So you see a QRS that's stretched out to 130 milliseconds. That is a huge red flag. This patient is on the verge of a life-threatening arrhythmia. So what's the most urgent thing you need to do right now? The answer is sodium bicarbonate. And here's the key point. It's not really about fixing the pH. It's about the sodium. You're essentially flooding the system with a huge load of sodium, which outcompetes the TCIA at those fast sodium channels in the heart. This kicks the drug off the channels, narrows that QRS right back down, and stabilizes the cardiac membrane. It's truly life-saving. Let's move on to our third section, where we're going to connect the dots between autoimmune disease, the stomach, and anemia. Okay, here's our next patient, a 56-year-old woman. We already know she has hypothyroidism, and she's been having this epigastric pain and bloating after meals for about a year. This is a case of autoimmune atrophic gastritis, or AMAG. And what's happening here is a double whammy autoimmune attack. First, you have autoantibodies destroying the parietal cells in the stomach. No parietal cells means no stomach acid, which leads to a crazy high gastrin level as the body tries to compensate. Second, you have antibodies attacking intrinsic factor. Without intrinsic factor, you can't absorb vitamin B12, and that leads directly to a B12 deficiency and the classic macrocytic anemia you see on the labs. So the huge takeaway here is the association. If you see a patient with one autoimmune disease like Hashimoto's and they have these vague GI symptoms, you have to check their blood count. If you see a macrocytic anemia, alarm bells for AMAG should be going off in your head. And because this condition increases the risk for gastric cancers, these patients absolutely need regular surveillance endoscopies. That's a key management point. And for our final section, let's talk about managing chronic liver disease and its complications. All right, our next case is a 47-year-old man. He has a history of heavy alcohol use. You can see the classic signs of liver disease on exam. And now he's showing up with new ascites, that's fluid in his abdomen. When you have new onset ascites, there's a clear workup. You have to do a diagnostic paracentesis. That means sticking a needle in and taking out some of that fluid. The most important first step with that fluid is to calculate the SAG, the serum to ascites albumin gradient. This simple calculation is what tells you whether or not this is all being driven by portal hypertension. And interpreting that fluid is everything. If the SA is 1.1 or higher, you know you're dealing with portal hypertension, most likely from cirrhosis. If it's less than 1.1, you start thinking about other causes like malignancy or TB. The other critical thing to check is the cell count. If the neutrophil count is 250 or more, that's your diagnosis for spontaneous bacterial peritonitis, or SBP, and that is a true medical emergency. Okay, our final case. We have a 41-year-old man. We know he has alcohol-associated liver disease. He's still drinking heavily, and his ascites is getting worse. Now, we have treatments for the symptoms, right? We can give diuretics to get rid of the fluid. We can give beta blockers to lower the portal pressure. But think about it. What's the one thing we can do that gets at the root cause of both the liver inflammation and the high portal pressure? And the answer may be obviously, but so critically important, is complete alcohol cessation. It is, without a doubt, the single most effective intervention. It's the only thing that actually reduces the inflammation in the liver, stops the scarring process, lowers the portal pressure, and most importantly, gives the patient a real survival benefit. So as we wrap up, think back on these 7 cases. Each one has a key differentiator that's crucial for exams. The difference between intestinal angina and simple indigestion. The continuous inflammation of UC versus the skip lesions of Crohn's. The superficial coagulation necrosis from acids versus the deep penetrating liquefactive necrosis from alkalis. Which one of those key differentiators is going to stick with you for your next exam?